Now we will start about connective tissue disorder. Connective tissue disorder, same rheumatological disease with autoimmune genesis factor, autoimmune disorder. They also strongly associate with genetically predisposition, human leukocyte antigen group for different disease. You know already different name. Mainly, we have 4 types of human leukocyte antigen group A, B, C, D, and they will be different for different disease. Connective tissue disorder characterized by the disorder of connective tissue like muscle, skin, vessel, ligaments, internal organs, and of course joints. In connective tissue disorder, don't think that only connective tissue will be damaged. Joints also affected, but mainly disease start and mainly complaints of patient will be about connective tissue disorder. Big percent of the connective tissue disorder disease are systemic lupus erythematosus, SLE, systemic scleroderma, systemic scleroderma, systemic sclerosis, it's one disease. Next, dermatomyositis. It's too big connective tissue disorder, very famous, very in statistic, very how to say, often we found this type of disease. But connective tissue disorder also means some different syndromes with connective tissue changes, like Sjogren syndrome, like Sjogren, for example, vasculitis disease with different vasculitis syndrome. Which else? Polymyositis. Okay, which syndrome also we have? Very famous. Antiphospholipid syndrome. Nowadays, antiphospholipid syndrome also very famous in all world, I guess, because antiphospholipid syndrome very often combined with different type of disease, autoimmunological disease. And about systemic connective tissue disorder, they are very often combined. It means patient might come with one type of symptoms first, which is more specific for one disease like SLE. Later, this disease might be combined with other type of symptoms, which will be specific for systemic scleroderma. Also, sometimes patients come with just one syndrome like Sjogren syndrome, and later doctor found that there is present second type disease, dermatomyositis, for like this. And if a patient comes with a combination of connective tissue disorder, don't forget to write each disease and first write mixed connective tissue disorder and combo and write which disorders here. And also interesting moment, if one disease in connective tissue disorder will be systemic scleroderma, which combined with other type of disease, for example, systemic scleroderma plus SLE, systemic scleroderma plus rheumatoid arthritis, systemic scleroderma plus dermatomyositis, it will be called overlap syndrome. For example, if rheumatoid arthritis plus SLE is just mixed disease. If there is one disease, systemic scleroderma with others, it's overlap syndrome. It's also its rules. Always you should write overlap syndrome or mixed syndrome, mixed connective tissue disorder. Now, systemic lupus erythematosus. Let's start about systemic lupus erythematosus. Why in definition we should say now about autoantibody production? Because there's a lot of autoantibody producing. and later they will be due to this production multi-system inflammation process. About statistic, about epidemiology, SLE affect young women. As usual, you know that young women more affected by connective tissue disorder, by the rheumatological disease, except two, gouty and ankylosing spondylitis. I hope you remember about this. SLE, okay, cause etiology as usual unknown, like unknown in each rheumatological disease, but we have trigger factors, risk factors which initiate disease, and there will be some genetical and epigenetic factors. Number 30 genetic polymorphisms here will be, and this Surendra, wait, okay, and this genetic and epigenetic factor specific for non-white women, common for African American women. Okay. And before some change of the cells, these patients already have abnormalities in the immune cells. Abnormalities immune cells, it means T and B cells. If you remember, in ankylosing spondylitis, in rheumatoid arthritis, before we didn't say it worked when they activate by some trigger factors. Here in these B cells. And internal factors, it's estrogen, as usual, estrogen high, sometimes early menarche, sometimes high estrogen might be triggered. Yeah, 9 times higher than men in women. And look here, age 15 to 45, when estrogen is high. Before I say it, when high estrogen also might be risk factor. Of course, SLE also can affect a child and old age, but it's not, but it's rare. And men also affected, also rare. Okay, come back for this. Other it's one big risk factor. So remember about this. Infection, as usual, Epstein-Barr viral infection. I always say of infection, viral infection, stress, cold, I don't know, stress, cold, pregnancy also might be risk factors for patient with some genetical predisposition, and drug. Sometimes drug might be induced SLE, and if it will be called drug-induced SLE, students. And we have special specific drugs which might be induced SLE. It is procainamide and hydralazine. Hydralazine, which more useful for in cardiology. I hope you know about this. Okay, done. Now, what happened in patient? Okay, 50 students. Okay, what happened in pathophysiology in patient with SLE? We have genetic predisposition. We have external trigger factors. You know, not all external trigger factors should calculate in one patient. Sometimes only one. The risk factors might be present in patients. Sometimes combination. It's not matter. And when internal risk factors and external risk factors combined, they activate some autoimmune response cells, and you already know that there will be abnormal immune cells, T cells, and B cells abnormality. A patient with SLE already have T cells defect, and that's why they will be work not properly. They can't normally do their function. They can't normally find abnormal cells which they should kill. They can't find them. They can't kill them properly because they are also not normal cells. But they try. In same time, B cells work in high percentage because they have a function of overactivation. It's also abnormal function of B cells. That's why when happens some change in body, it's about T cells defect and activation of immune responsible cells. B cells produce in high level antibody, and due to the abnormal they produce autoantibody. What it means? B cells start produce antibody against our own cells. How it's happened? How it happened? One second. Okay. We have, for example, skin, for example. Skin affected. Little bit some change of skin, yeah. High melanin produced, so I don't know, some keratosis due to ultraviolet light, so some change, different changes might be. And when this part of skin little bit change, these cells become two abnormal cells, or they die early than usual apoptotic process. You know that finally all type of cells die, but due to ultraviolet lights, for example, they die early than usual. And when they die, T cells start attack them because they have defect, they are not normal, and mistakenly they recognize our own cells like antigen. They recognize our own tissue like antigen because they work not properly. And look at here, not only with skin, this problem might be problem with lung, with heart, any type of internal organ or other part of the body might be first organ which start some specific changes. Lungs might be changed a little bit due to smoking of patient. In this situation, same situation. Due to this smoking, maybe some part of the lung change, and T cells again recognize them that like antigen and start activate. And they will be over producing of some type of inflammation cells, other population macrophages, interleukins, which always work when they think that they start some inflamed process. And B cells, what do B cells in this moment? B cells from T cells take information that there is some problem, and they should start produce antibody. B cells normally produced specific antibody for specific disease. Here also they produce some specific antibody, but problem that they produced antibody against this organ, because T cells already say that there is some antigen. They recognize our own type of cells like antigen. That's why B cells mistakenly start produce antibody against our own antibody or our own body cells. That's why they inflame cells, macrophages, interleukins, etc. Stop process of inflame here. In same time, B cells antibody again damage new type of cells because they produce auto antibody. And again, new population of these cells attack this part of body, because B cells which produce antibody give again antibody, auto-antibody, again they damage new normal cells which become to abnormal, and again inflame start here, and this change repeat without stopping. That's why there will be a multi-system inflame process, because this antibody later attack other part of body. They produced out antibody again and again and again without stopping. That's why there will be multi-system organ damaging with producing of auto antibody in high level. About this, we said in in definition, producing of auto antibody, and 1 second. Next slide. And antibody antigen complex formulate, we know about this. And as I said, they will be deposited in the immune complex. About tissue, I already said, like lung, skin, heart, kidney, joints, etc. And that's why there will be some type of specific change. 1 second, friends. Sorry. Okay, 1 second, I will switch off my video. Okay, students, I should switch off my video. Okay, now I'll continue. And there will be multi-system organ damaging. As I said, in this picture, you can understand that everything might be affected by the immune complex antibody antigen in body, heart, skin, vessels, kidney, joints, etc. That's why SLE, one of the dangerous disease in rheumatological system. Okay, done, students? Do you understand this?
Yes, ma'am.
Okay, great. Now I want to tell about antibody. Here we have overactivation of B cells, which produce different type of antibody. Please take your pen and write name of this antibody. There is a lot of antibody. If we said that for rheumatoid arthritis, we have 2 type of antibody. In ankylosing spondylitis also, I said only 2 type of antibody, anti-nuclear and anti-neutrophil cytoplasmic antibody. RF factor minus, I said in ankylosing spondylitis. In SLE, there will be a lot of antibody. For example, anti-Smith antibody, right, please, anti-Smith antibody, anti-DNA antibody, anti-phospholipid antibody, anti-cardiolipin antibody, beta-2 glycoprotein antibody. We have also connective tissue antibody. Yes, a general antibody for connective tissue disorder. We have LE cells, specific LE cells. I will explain after the antibodies. What is it? LE cells. LE cells. We have 1 second for remember, for example, lupus anticoagulant, anti-Smith. 1 second. And also you can write anticardiolipin, I already said, beta-2 glycoprotein antibody. And 1 minute, which antibody also matter for us? Anti-RO antibody, anti-RO antibody, students. Anti-RO antibody. Second, which antibody it's also matter? I guess this mainly. Rheumatoid factor antibody, general antibody sometimes might be positive, sometimes negative. It's not so specific. And as usual, anti-nuclear antibody, we always check this. Anti-nuclear antibody, if you remember before, I said in rheumatoid arthritis and antiphospholipid syndrome will be positive in 30%. But for SLE, anti-nuclear antibody have high specificity. That's why anti-nuclear antibody also one of the meta antibody for SLE. And also you can complete with anti-neutrophil cytoplasmic antibody. Sometimes if one antibody absent, you can check other antibody to be proved and be sure that there is some immunological disorder present. This type of antibody you can find in SLE. But students, when you will read literature, don't worry if you found other antibody. It will be great. In practical part, we will discuss other type of antibody also. Now, clinical manifestation of SLE. In this picture, we already found that this patient have problem in all part of the body. Let's start from the hair. Patient with SLE complaint will be to diffuse hair loss. Diffuse hair loss, like in this picture, it's called alopecia. Alopecia, there will be diffuse hair loss. Diffuse hair loss, and patient sometimes might be have a problem with skin first, and that's why they usually go to the dermatological doctor because first symptoms of the patient with SLE very common. That's why it's hard to understand the patient have SLE, students. Okay, next, in this picture, hair alopecia, more down, eyes, keratitis, uveitis, flame of the eyes, and very often there will be dry eyes. In SLE, yeah, dry eyes, it's also one complaint of the patient with SLE. Dry eyes, how called syndrome, how called syndrome, and patient complain to dry eyes, students. In rheumatoid arthritis lecture, I said about this syndrome. How called this syndrome? Remind me, please. Tavinda, you remember? I said about this in rheumatoid arthritis lecture. The patients sometimes have dry eyes, and this syndrome very often have patients with SLE. Who remember, students, dry eyes?
Ma'am, conjunctivitis.
No, not this. I said the patient complains to dry eyes, but if you will pay attention, you also notice.
As John, ma'am. As John.
Shahrukh? Repeat.
Ma'am, Zika syndrome.
Sjogren syndrome. Sjogren, student.
Yes, ma'am. As John.
Yes, Sjogren, Shahrukh, correct. Yes, I understand what you said. Sjogren syndrome, students, remember about this syndrome. Sjogren syndrome mean dry mucus. dry eyes, dry mouth. Women also notice that there's dry vagin. It's also mucous tissue, as you know. And patients sometimes come to consultation and complain to the dry mucus. And if it will be a very attention doctor, he should understand that there is some immunological process start. Why they will be dry syndrome? Because salivary glands affected. Also tissue of the body is salivary glands, and they will be affected salivary glands, all type of glands which should be work in mucus, mucus, and there will be affection, and like in symptoms we will find symptoms like dry symptoms, Sjogren syndrome. I remember one patient. This patient was relatives of my friend. First, this patient come to doctor with dry eyes. It was just dry eyes. First, he go to ophthalmological, then to therapist, general practitioner. But later they start SLE also, I remember. First, they treat this patient like usual patient of ophthalmological doctor, but later they understand that there is dry mouth, dry vagin, and later they start problem with joints, with connective tissue also. That's why if in your future practical life you found patient with dry syndrome, be attention. It might be a beginning of some serious disease. Next, nose. Very often patient complains to nose and oral ulcer without reason. Without reason, they found ulcer. This ulcer also not treated by usual drugs. Next, about cheeks. Now I should say that patients with SLE very often complain to the different type of rashes. There will be different type of rash, students, but for us, mainly two type of rash. It's erythematosus rash and discoid rash. Erythematosus rash we can find on cheeks and dorsum part of nose, like this. It's look like look like the shape of butterfly. That's why patient with this type of rash, if they have this type of rash, if you found, you can call butterfly rashes. Now I want to say one thing, big attention. Butterfly rashes, they located on cheek and dorsum part of nose. In dermatomyositis, we have also erythematosus rash on cheek, but without dorsum part of nose. That's why you should be attention for differential diagnosis. If patient comes with erythematosus rash on cheeks, you should be attention and check here present or not, because there's two different diseases: dermatomyositis without dorsum part and SLE with butterfly shape. Next, discoid rash, students. Discoid rash start from the neck, and mainly they affected neck, V zone. This area is called V zone, yes, like V. And hands. It will be look like this. It is discoid rash. About neck, there is a lot of lymphs, yes, submandibular, neck lymphs, and there will be lymphadenopathy. Patient also notice and complains to lymphadenopathy. There will be big lymphs without reason. It means, what means without reason? Usually lymphs enlarge when we have some bacterial infection. Here, patient have not bacterial infection, but lymphadenopathy present. Okay, here start joints. Yes, joints. About joints. The joints affected, there will be arthritis, inflammation of the joints, but you should understand there will be not symmetrical arthritis, non-erosive arthritis. About localization might be affect small and large also. And about some specific moment, if patient will be man, very often affected the head of the femur. And very often there will be aseptic necrosis of head of the femur. Please remember, students, in SLE might be necrosis of bones, mainly head part. Students, do you understand what I say?
Yes,
Are you
ma'am.
here? Okay, great.
Yes, ma'am.
Yes, ma'am.
Okay, I'm continuing. About go down lung, lung. Okay, pleuritis, bronchitis, they might be, they might be pleuritis, bronchitis, sometimes might be hemorrhage, pulmonary hemorrhage. Now I want to come back to antibody. If you remember, I said there will be anticoagulant antibody. And I forgot about LE cells. Okay, I will tell in diagnosis what mean LE cells. Anticoagulant antibody, they will be anticoagulant. Okay, anticoagulant antibody mainly responsible for hemorrhage. There will be hemorrhage due to the presence of some antibodies which attack thrombocytes, and there will be a hemorrhage in lung. One reason of this hemorrhage, and there also might be fibrosis of lung. Remember about this. Heart, endocarditis, atherosclerosis, pericarditis, no problem. No problem. It means there will be different changes of heart, and one specific change, it's endocarditis, which specific for SLE, which called Liebman-Sachs endocarditis. Liebman-Sachs endocarditis, what it means? It means patient have endocarditis, but without bacterial infection. You know that one reason, big reason of endocarditis is bacterial infection, but there will be a bacterial infection of heart, endocarditis without bacteria. It's called Liebman-Sachs endocarditis. Just 1 second. Liebman-Sachs endocarditis. Liebman-Sachs endocarditis. Написано на лекции, я вам позже напишу, позвоню или Liebman-Sachs endocarditis. Так, да, kidney. Kidney, it's one organs which affect, I guess, in SLE patient have problem with kidney in 70–80%. There will be glomerulosclerosis. There will be a glomerulosclerosis and glomerulonephritis, one reason of the glomerulosclerosis, you know. And if patient have problem with kidney, like glomerulonephritis, it will be called lupus nephritis. Lupus nephritis. Anjay, sorry.
Yes, ma'am.
You said something
Yes, ma'am.
about what, Anjay?
Ma'am, like hematuria, like condition, ma'am.
Hematuria, it's one symptoms just of the glomerulonephritis. Here about this written that mainly symptoms which notice patients blood in urine, hematuria. Hematuria, it's one big symptoms of glomerulonephritis, as we know. And 1 second. Okay, Tabinda, yes. It means about 30%. It means about lupus nephritis, Tabinda. but about different small symptoms, 78%. For example, if just here small pyelonephritis or small or some little bit changes, no problem. In common 30%, but or 70%. But when real lupus nephritis tabinda, 30%. Okay? Because lupus nephritis, yes, about lupus nephritis, 30%, correct. Because when patients have lupus nephritis, you know that why it's dangerous, because usually patients with lupus nephritis, they need hemodialysis. A big percent of the glomerulus die, and they need hemodialysis procedures in special department, as you know. And blood. In blood, there will be also big reasons, anemia, about high blood pressure. High blood pressure will be if kidney affected. Before patient with rheumatological disease, first, if there is no real arterial hypertension like disease, patient without kidney problems in rheumatology, first they have low BP. And later, if there will be problem with kidney, of course, SLE will be associated with high BP. Okay, Mohammed, can you remember this question? In practical class we will discuss, okay? If finally I will have time, I will also try to discuss, okay? Now, 1 second, I will write your question to don't forget. Okay. In diagnosis, I will write and I will try to explain. Okay. In blood, there will be also decreased count of different part of the blood cells, not only the anemia. They will be decreased thrombocytes. They might be low leukocytes also, thrombocytes, leukocytes, hemoglobin, because they die due to autoimmune complex, and if they will be decrease all type of the cells in blood, it will be called pancytopenia. If they will be hemoglobin decrease, it's called anemia. If thrombocyte decrease, it's called thrombocytopenia. If leukocytes decrease, it's called leukopenia. If decrease all type of the blood, it will called pancytopenia. Remember about these students. Pancytopenia, it's also weak changes of the patient with SLE. And why decrease hemoglobin? There is one reason why decrease hemoglobin. They might be due to immune complex, and also there might be a second reason due to kidney problem. If kidney affected, you know, kidney responsible for producing erythropoietin. Erythropoietin is hormone which produce, which worked in erythropoiesis. And of course, if decrease erythropoietin, there will be anemia. And you should also remember a little bit, I will tell about hemodialysis patient which have problem with kidney. When there will be glomerulonephritis in lupus nephritis, as wrote Tabinda, 30% of patients with SLE have lupus nephritis, and they really need hemodialysis in final stage. They in this department, they take hemodialysis, and also they do always injection of erythropoietin. It's injection, they do erythropoietin injection because they stimulate erythropoiesis, because without this hormone, there will be absolutely no erythropoiesis. Okay, go down. Okay, about bone, I said, joints, I said, about tract and reproductive system. Patient with SLE, of course, have some infection problems. Urogenital tract infection will be, they will be, because immune system is not work properly, and there should be attention because even there will be small infection, our immune cells can't work properly. About reproductive system, woman, woman, okay, men have give birth. Okay, men's reproductive system will be normal. There's no problem. Women, they can't be pregnant but can't give birth baby because there will be abortion. Due to immunocomplex, very often there will be abortion. And very often, a little bit about antiphospholipid syndrome. Very often, patient with SLE, if it's woman, they combine it with antiphospholipid syndrome, where will be a positive antiphospholipid antibody and anticoagulant antibody, which are responsible for hemorrhage, and there will be placentaric pregnancy, there might be hemorrhage and abortion. Muscle, okay, about muscle, okay, inflame of muscle also might be, that's why patient feel pain. About small joints, I remember patient with SLE, it was man, his fingers was defigurate, there was deformation and defiguration of the fingers, I remember, but I'm not sure that it was SLE, just maybe he have also problem like rheumatoid arthritis, that's why there was deformity, because in literature, usually about deformities we didn't write. Of course, there might be some problems with joints. Due to this, there will be deformities in different size, maybe. But I remember that this patient with SLE have necrosis of fingers in distal part because connective tissue problems, and you always should know that peripheral part of body always will be affected first because there will be hypoxemia, less of the oxygen and circulation. That's why patient with SLE always need treatment not only of rheumatological doctor, they always need treatment of combination of patient doctors. Okay, now it's big changes. Now, what about, I forgot to say, fatigue, depression, sleep problems, weight loss, it's common symptoms which patient might have in beginning of disease. As usual, they don't understand why they have headache, why they have fatigue, and go to therapist, go to neurologist. Weight loss as usual, but photosensitivity, it's one symptoms which start in early stage, and by this stage or by these symptoms you can already think about SLE, because photosensitivity really one of specific symptoms of SLE. Nausea and abdominal pain might be, and what about also I forgot, fever. Oh, okay, fever. I don't know, I don't remember I said or not before, but patient with rheumatological disease, rheumatoid arthritis, ankylosing spondylitis, SLE, dermatomyositis, other type of disease in rheumatology, patient complain to low-grade fever. They complain for low-grade fever. Yeah, without reason, no bacterial, just low-grade fever. Seizure psychosis also might be. Seizure psychosis. Okay. Neurological imaging will be big for patient with their SLE. Now, how we how we do diagnosis of SLE, which type of lab test and imaging test we should check. For laboratory, okay, you should always check a routine test. You know what I mean routine test? It is common blood analysis, function test, kidney function, electrolyte panel. All this matter for patient is rheumatological disease, because if you found change, you should correlate them, give correct treatment, combination of treatment, not only basic treatment. But at the same time, don't forget about mainly the lab test, it means antibody test. We will check again, I repeat, NA, anti-nuclear antibody, anti-dsDNA, anti-SMIT, and now interesting fact that anti-dsDNA antibody suggests lupus. If you found it suggests lupus nephritis. If you found in early stage anti-dsDNA, maybe you should think about nephroprotection treatment. Already start nephroprotection treatment, even if there is no symptoms, but I guess usually there will be symptoms. And if you found anti-SMIT antibody, it doesn't correlate with lupus nephritis, it's good. It means in 30% of patients, you will find anti-dsDNA antibody. Antiphospholipid antibody, if you found antiphospholipid antibody, please check anticardiolipin, anti-2 glycoproteid, and lupus anticoagulant to be sure that there's present or not antiphospholipid antiphospholipid syndrome, APL. Then you should check complement system number 3 and number 4. Because complement system will be decreased because immune cells decrease, complements responsible for immune system, and low level also suggests active lupus, suggests active phase, because when you treat correctly, when you again check if your treatment correct, it will be increased again, it will be normalized a little bit. About inflamed biomarkers, you know, always is reactive protein and ESR suggest active phase of SLE if they will be present in high level. And LE cells, before I say it about LE cells, it's lupus erythematosus cells. This type of cells you also will be found. You will find in SLE. LE cells. It's previous macrophages. It's previous macrophages which eat cells which die due to abnormalities of these cells. For example, 1 second. Look here, macrophages. What their function? Eat cells after apoptosis, correct? After normal apoptosis, they eat, and it's normal process. But when patients have SLE, these macrophages eat these cells, but these cells not normal. Yes, they die. But why they die? Because they are already not normal cells. They die due to sunlight, ultraviolet light skin, or due to smoking. They already was changed, their structure changed. They was attacked by T cells, etc. And their structure a little bit different, but they it was eaten by macrophages, and these macrophages when circulate in blood, you take test, and if you found these LE cells, of course, these macrophages will be a little bit different than usual macrophages. This type of cells will be called LE cells. LE cells are more specific for SLE. But LE cells also you can find in systemic scleroderma, and if I'm not sorry, and if I'm right, under microscope in SLE, you should find 5 LE cells. if you found in one vision by microscope 5 ALE cells, it means SLE present in this patient. Okay. LE cells, yeah. This is mainly tests. I should, 1 second. Okay, LE cells. Oh. Okay, except antibody test, always we do imaging test, yes? Imaging test, they will be very informative for SLE if you think about different if you think about SLE, you should check imaging test of all organs, ECG to heart, EMG to muscle, electromyograms to exclude dermatomyositis, because sometimes connective tissue disease is a little bit confused doctors. That's why for differential diagnosis you can do some tests. X-ray of joints, you will find non-erosive arthritis, chest X-ray because there might be a lung disease, echocardiograms to find pericarditis, or Lehmann-Sachs endocarditis. What else? MRI of brain, MRI of heart, MRI of the internal organs, ultrasound of internal organs, first of all. And 1 second, there was question. Muhammad Abdul, you asked me about how we can differentiate. Muhammad, are you here?
Yes, ma'am. I'm here.
Yes, you said about how we can differentiate between pleural and precardial ram. Okay. First, we will First we check by auscultation, Muhammad, place where we hear this ram.
Yes,
this ram. Yes, it's usual for me like this place. And also by imaging test, you can prove by X-ray, for example, if you found that there is effusion, you can prove that there is pleural rub was here. Or in echocardiograms, if you found some pericarditis, you can prove that, oh, okay, it was pericardial rub, like this. Like this. Or something else, Muhammad, maybe I didn't properly understand your question.
My question was, how can we differentiate between pleural rub and pericardial rub?
Yeah. First, auscultation, just.
Yes, ma'am.
By auscultation, we can, by auscultation, we check 5 points in the heart points, yes?
Ma'am, like in auscultation, ma'am, how can we differentiate, ma'am?
Just place we will choose where we auscultate. For example, if we check lung, we heard this rub in lung place, in lung points. If we heard this rub in heart points, it's heart rubs, like this. It's simple, I guess, for me. For example, yes, like this, because place point where you hear this rub, it matter for you. And to be proved, you can differentiate by the imaging test like this. I guess it's not hard to differentiate, because when you will be practical doctor, by auscultation, you will choose place where you should check and understand it is pleural or pericardial. That's why Muhammad a little bit I confused, because just by auscultation you will choose points where you will heard pleural or pericardial, Muhammad. Like this. What do you think?
Ma'am, I think ma'am, like when we like if you hold the breath, ma'am, and if you hear the pleural sound, ma'am, of the like in pericardium, ma'am, then we can decide it is pericardial rub. And when we will take a patient to ma'am like breath in, and if we hear the frictional sound, then we can ma'am diagnose it as like pleural rub.
1 second. We can do test, okay, for differentiate.
Ma'am, also you can also do the echo, ma'am. Like in echo, ma'am,
Yes,
the heart shape will be like
yes,
1
as I
bell.
said, imaging test. X-ray and echocardiograms can prove it's pleural or pericardial. But if you live in village and it's impossible to check by imaging test, but you should write in history it's pleural or pericardial rub, you can do test. You can do test. You know how we do this test? Yes, now I remember when I was students how to treat our teachers. When patient have some rub, if you will ask to take deep breath and stop breathing, but you up, it will be pericardial rub because lungs don't breathe, it stopped, yes? Heart beat. That's why there will be rub. Like this also differential diagnosis you can do, Muhammad. This test I like, yes. Done?
Yes, please.
Yes, this test it's very useful. Now I remember, now I guess now like this it will be correct answer for your question. If you want differentiate now when patient come without echo and X-ray, okay, do this test. Take breath and stop breathing. Deep breathing and stop and continue to listen. Because when lungs stop to breathe, you know, they will stop rubs, yes? Because rubs usually will be when breathing in pleural. But heart also continue to beat.
Yes, ma'am.
Yes, even we stop breathing, you know, heart will be beat some time while we have oxygen. In this condition, you can find and differentiate is pericardial or pleural rub. Okay, this is about how we will diagnose the SLE. In disease, in history of patient, in history of patient, in his application, you should write SLE, you should write stage acute, subacute, chronic. Then you should write which type of change have this patient. You should write heart, and in brackets you should write pericarditis, comma, you should write lung, pleuritis, comma, like this. You in SLE patient, it's necessary to write each change which you will count, because in next time when patient come, if there will be other doctor or if you will be again, you should compare condition of patient. There will be increased symptoms or decreased. That's why it's necessary to write all change of SLE patient in his history of disease. And again, criteria. We have criteria by American College of Rheumatologists. We have 11 criteria. And I guess 4 there should be 2 definitely rheumatoid arthritis, or SLE, yes. 4 criteria you should found by this 11. First, malar rash, discoid rash, photosensitivity, oral ulcer, arthritis, serositis. Serositis means effusion of pleura and heart, pericarditis and pleuritis, renal disorder, neurological disorder, hematological disorder, immunological disorder, anti-nuclear antibody. There's 11 criteria. And if you found 4 criteria of all these 11, it definitely, definite, yes? Correctly, definite? How it's read? Definite, student. How correctly read this word?
Definite.
Definite, definite, yeah, definite. Okay, definite. It's definite SLE. For example, if you found malar rash, photosensitivity, because malar rash usually caused by the initiated by the photosensitivity, malar rash, photosensitivity, arthritis, yeah, for example. And why not you check test and found anti-nuclear antibody, already 4 criteria, and you can be sure that it is SLE.
Ma'am, I have a
Yeah.
question.
Yes.
Ma'am, what type of oral ulcer can we find in SLE?
I already said oral ulcer or nasal ulcer. It also might be. It's looked here. Special for students like you. It's joke, Mohammed. In the right part, there is explaining again. We already said often painless oral or nasopharyngeal ulceration, like this. It's painless. Usual ulcer, which might be in each person. For example, do you have before Mohammed ulcer in your mouth?
Yes, ma'am.
Like, but they are usually painful, correct?
Ma'am, can you repeat the question?
They're but usually painful, Muhammad. Yes, this ulcer.
Yes, ma'am.
Yes, I also have ulcer due to some stomatitis, for example. Yes,
Yes, ma'am.
but patient with SLE, they have painless oral ulcer or nasopharyngeal also might be. About arthritis, non-erosive 2 and more peripheral joints. Arthritis will be. And look at here. Students, be attention now. Students always confused and again saying not correct criteria. Immunological disorder, immunological consists by the positive LE cells. You already know what is it. Anti-DNA, anti-SMID, or false positive serological test for syphilis. This is immunological test. Not all should be present. If there will be 1 test or 2 tests, it's already immunological disorder positive. And anti-nuclear antibody, it's often criteria. Anti-nuclear antibody, it's also immunological disorder, but in criteria, it's often criteria because high titer of anti-nuclear antibody were specific for SLE. And if you found very high level, it maybe might be drug-induced SLE. And anti-nuclear antibody also in drug-induced SLE, you can find with anti-nuclear antibody. 1 second. Other type of antibody, anti-histone antibody. Anti-histone antibody. It proved that there is drug-induced SLE. In situation, if it's drug-induced SLE, first step, stop this drug, students, okay? And you will continue usual treatment of SLE. How you will treat your patient with SLE? Patient with SLE, there will be decreased disease activity. It's aim of the patient treatment, prevent organ damaging, reduce use corticosteroid because patient with SLE unfortunately use high dose of corticosteroids, and there will be big side effects of corticosteroids. You know about this. I already said there will be a lot of side effects of corticosteroids. Reduce drug side effects. Why Dawood want to join after 1 hour, more than 1 hour? Why Dawood want to join, students? He was present before, I guess no. Dawood, which group?
Group 3, ma'am. Group 3. Dawood.
He joined right now or before he
No,
was
ma'am.
joined?
Actually, his internet was weak, ma'am. He
Okay,
was
I
already in the
will.
class.
Okay. 1 second. Okay, and sorry, my son was a bit crying. Reduce drug effect. drug effect and to improve quality of life. How we do all these aim goals? We will give symptomatical therapy, suppressive immunosuppression therapy. We'll give mainly we can say basic treatment and symptomatical treatment. Symptomatically, as usual, NSAIDs, aspirin, ibuprofen, diclofenac. Aspirin will be good if there is also will be heart problem. Corticosteroid, as usual, prednisone. Now antimalarial and biological, it's basic drug. And DMARDs, azathioprine, mycophenolate mofetil, cyclophosphamide, methotrexate, drug of choice. Here, I will not say because in SLE we always choose individually. For one patient, maybe azathioprine will be good. Azathioprine with prednisone very good in combination when the patient have fibrosis of lung. Methotrexate if patient with SLE also have a problem with joints like this. That's why there is no one drug like choice of drug. You will be choose which good for your patient. I just can say only about prednisone. We have pulse therapy. Pulse therapy. You know that pulse therapy are very useful in rheumatological disease, but mainly we will give in patient with SLE. We will give high dose of corticosteroids like this. Do you remember I said before 5 to 10 mg, it's middle dose for long time, if you remember, yeah? When patients have high activity of disease, when patient come for first time to hospitalization, we'll give 1 mg per kg, maximal 60. And again, one second. And again, I repeat for you. Look here, 5 to 10 mg, it's middle dose. After this dose, maximal 60. Patient come for hospital, high active process. You will give 1 mg per kg, maximal 60. Later, when you decrease symptoms, you decrease 60 to 5 to 10 mg and give пожизненно. But we have other condition. When patient come with complication of disease, what mean complication? It's serositis, lupus nephritis, Caesar psychosis, and corticoresistance. All these conditions might be rules for pulse therapy. We will give super high dose of IV for 3 days. Done? For 3 days, very high. It's called immunosuppressive therapy. After this, we come back for this treatment. What is pulse therapy? Do you understand? Are you here?
Yes, ma'am, we are here.
Super high dose of corticosteroids, it's pulse therapy. Okay, simple. If corticosteroid is not useful or due to something you decided that corticosteroid not effective for this patient, you can do with cyclophosphamide, for example. You can do with DMARDs sometimes and often used by cyclophosphamide. For cyclophosphamide, if I'm right, 600 mg by IV. This dose was for cyclophosphamide. I remember pulse therapy by cyclophosphamide useful in ankylosing spondylitis. I remember about this. This is how you treat patient with SLE. And of course, you should organ protection treatment, treat comorbid conditions, necessary to check lab test each 6 months because due to side effects might be affected other organs. I think I forgot something I want to say. Nephroprotection, about nephroprotection, students. About nephroprotection, what I want to say, if you notice that patient have nephro problems, you should give AC inhibitors or which second drug nephroprotection effect have? AC inhibitors or who know?
ARB, ma'am.
Yeah, correct. They look like the same group. They work in RAS systems, yes?
Yes, ma'am.
But these two never should be combined. Never combined. Or only one, okay? These drugs called nephroprotection drugs, very useful in patients with lupus nephritis. If patient have glomerulonephritis, glomerulosclerosis like this. Okay, do you have question about SLE? No question. Okay, break time, please. Break time, and we will continue our second lecture after, I don't know, maybe 30 minutes, because my baby crying, I should, he want to sleep, I will join after when he will sleep, okay? I guess 30 minutes. I will inform students, leaders to join to class. Take break, take rest, and rejoin. Do you understand?
Okay, ma'am.
Okay.
Yes, ma'am.
Ma'am.